Stroke is a major cause of mortality and morbidity. As summarized in this slide, it usually affects elderly people. But it's also present in younger population. The vast majority of stroke are due to ischemia. Cardiac embolism is responsible for about 14% of total strokes, and left atrial appendage thrombosis is present in 60 to 80% of all the cases. Different score systems help the physician to orient in the risk stratification of stroke and bleeding. Persistent supraventricular tachycardias are responsible for left atrial appendage thrombosis and, in some cases, for dementia occurring after subclinical events. Ablation is an elegant solution for stroke prevention, but unfortunately, some patients are not suitable for arrhythmia ablation, or poor outcome on long-term follow-up is expected by the physician, as in advanced left atrial fibrosis. Other possible strategies to prevent stroke are medical treatment such as vitamin K antagonist, antithrombotics, direct thrombin inhibitors, and antiplatelet. Interventional or surgical procedures for sealing of thrombogenic foci is also possible. The left atrial appendage is a finger-like outpouching of the left atrium. It is composed by a main cavity and a variable number of lobes. A lobe is defined as a cavity able to host at least a 2 mm probe corresponding to an external crystal. The most common morphology for the left atrial appendage is found to be the bilobed one. Any of the left atrial appendage lobe can lie on a different plane and change the direction respect to the main body. That makes necessary to use different echoprojection to completely explore this anatomical structure. The left atrial appendage can be morphologically classified as crooked finger and stump-like. The left atrial appendage showed a very important role in water and sodium homeostasis, and its endocrinal function is made through the secretion of atrial natriuretic peptide and brain natriuretic peptide. AMP is secreted in response to variation in hemodynamic balance, oxytocin, adrenergic stress, hypoxia, and myocyte stretch. The production and releasing of ANP and BNP will affect the function of the renal system, cardiovascular system, and the adipose tissue metabolism.
Hello? The patient that we have today is a 76-year-old gentleman with a history of hypertension and diabetes who suffers from chronic atrial fibrillation that was discovered in the year 2006. 4 months after the initiation of oral anticoagulation, he suffered a major hemorrhagic stroke with significant motor impairment, and from this he recovered pretty well, and he is now left with minor functional impairment. On echo evaluation, he has a severe enlargement of the left atrium, a mild to moderate mitral regurgitation, and a normal ejection fraction. On transesophageal echo, the appendage is completely free from thrombi, has a low peak velocity, and the transverse diameter at the ostium is of 16 millimeters, at the landing zone for the device is 13 millimeters. The procedure is going to be performed under general anesthesia. We are going to have invasive blood pressure monitoring. The ACT will be kept in a range of 250 to 300 seconds by intravenous heparin infusion, and the procedure is going to be guided by transesophageal echo and fluoroscopy. So the first step of the procedure is going to be the transeptal puncture. We are going now to advance the introducer up to the SVC. Now we are ready to advance the needle into the introducer, which I have already placed in the superior vena cava, and with the flange of the needle oriented 45 degrees posteriorly, I pull back the introducer. You see on the echo that I am tenting the fossa ovalis. And we have done the transeptal. Now I confirm the position with contrast. And we are into the left atrium. And I will advance the introducer right now. We have evaluated the mean diameter of the appendage in the range of 14 millimeters, so we think we are not going to place a device larger than 20, and this requires a 10 French introducer. So to advance, first I will put an exchange wire in the introducer and advance it into the left atrium. The guide wire went straight into the appendage. I will keep it there and take advantage of this position to advance the introducer. So I will first pull back the first transeptal sheath, keeping the guide in place. Now the groin introducer, the 10 French. We have to enter the left atrium with this introducer, which is a dedicated one for the device. The delivery system is now in the appendage and it is manipulated gently to avoid perforation. The dilator is removed and some blood is allowed to leak to avoid any entrapment of air inside the delivery system. The next step is the radiological measurement of the appendage. I will do an injection in RAO caudal. So now we measure and then we'll decide the diameter of the prosthesis. We do the calibration on the shaft of this catheter, which is a 10 French catheter. So 10 French is about 3.3 millimeters. So we do the calibration. Now we have to select the appropriate image. Stop, good. And we measure the neck of the appendage, which is going to be our landing zone. We have selected a steel frame from the caudal RAO, which is the best projection to do this imaging, and we do the measurement. Please do. So we are around 16 millimeters, and I think we should do another one to make sure. Select another frame. Next. Okay, this is the best. Let's do another measure. The diameter that we have estimated is 17 millimeters. To select the prosthesis, we always have to oversize a bit. In this case, I think it is appropriate to use a 20 millimeters prosthesis. This slide shows the reference card to select the diameter of the prosthesis based on the diameter on the landing zone. You see that the minimal orifice depth required to make the implant possible is 1 centimeter, and the maximum size of the appendage suitable for the implant is about 28 millimeters. If the diameter of the prosthesis is properly selected, the distal disc should be minimally squeezed by the appendage. If undersized distal disc is not affected in whatsoever matter by the appendage, oversized, you have this kind of strawberry appearance, which means that the distal disc is squeezed too much and there is a heavy risk of dislodging.